Okay, today we're going to talk about overactive bladder. Since we do a fair amount of studies on this indication, I think it would help quite a bit if we all had a better understanding. So let's get started. According to the Urology Care, overactive bladder is a common condition that affects millions of Americans. About 33 million Americans have OAB. 30% of all men and 40% of all women in the United States live with OAB symptoms. But the number of people suffering from OAB is most likely much larger. And that's because people living with OAB don't ask for help. Some are embarrassed and they really don't know how to talk to their healthcare professional about their symptoms. Other people don't ask for help because they don't think that there are any treatments for OAB. OAB isn't a disease. It's actually the name given to a group of urinary symptoms. The major symptom of OAB is that gotta go feeling, the sudden strong urge to urinate that you can't control. Another symptom is that patients may also worry that they won't make it to the bathroom in time. Patients may or may not leak urine after feeling this urge. Patients with OAB may experience a variety of symptoms. Leaking urine or incontinence is one of them. Sometimes people with OAB also have urgency incontinence, and this means that the urine leaks after they feel that sudden urge to go. This isn't the same as stress urinary incontinence or SUI. Women with SUI leak urine while sneezing, laughing, or coughing, or doing any other physical activity. Sometimes it can be just standing up from a seated position. Another symptom, patients may also need to go to the bathroom many times during the day, and the number of times someone urinates varies from person to person. But experts do agree that going to the bathroom more than 8 times in 24 hours is considered frequency. Having to wake from sleep to go to the bathroom more than once a night is another symptom of OAB, and we call this nocturia. What are the causes of OAB? The bladder and the kidneys are part of the urinary tract, the organs in our bodies that produce, store, and pass urine. You have 2 kidneys that produce urine, then urine is stored in your bladder. The muscles in the lower part of your abdomen hold your bladder in place. When it isn't full of urine, the bladder is relaxed. When nerve signals in your brain let you know that your bladder is becoming full, you feel that need to urinate. Then, the bladder muscles squeeze and push urine out through the urethra, the tube that carries urine away from your body. The urethra has muscles called sphincters. They help keep the urethra closed so urine doesn't leak before you're ready to go to the bathroom. OAB, the nerve signals between your bladder and brain tell your bladder to empty even when it isn't full. OAB can also happen when your bladder muscles are too active. Then, your bladder muscles contract to pass urine before your bladder is full, and that causes a sudden strong need to urinate. And we call this urgency. So as you grow older, the risk for OAB symptoms increases. Both men and women are at risk for OAB. Women who have had children and/or have gone through menopause and men who have had prostate problems seem to be at a greater risk for OAB, as are people with neurological diseases such as MS and those who have had a stroke. So how do we diagnose OAB? As with any other disease, we need to gather a thorough history of the patient's past and current health problems. We need to know what symptoms they're having and how long they've had them, as well as what medications they take and how much liquid they drink during the day. We'll also do a physical exam to look for something that may be causing the symptoms. And this is going to include an examination of the abdomen as well as the organs in the pelvis and rectum in women or prostate and rectum in men. We'll also collect a sample of urine to check for an infection. We may collect a sample of blood, and in some cases, we may do a urine culture or an ultrasound. We'll also have the patient keep a bladder diary to learn more about their day-to-day symptoms and to have them record their voids or micturations. What treatments are available for OAB? There are several treatments available, and the first therapy is the behavioral therapy, and these are lifestyle changes. In behavioral therapy, patients make some changes in the way they live day to day, and this may include changing their diet to see if less caffeine, alcohol, and spicy foods will reduce their symptoms. We may have them keep that daily diary to track their trips to the bathroom, and behavioral changes may include going to the bathroom at scheduled times during the day and doing Kegel exercises to relax the bladder muscle in women. Most patients don't get rid of their symptoms completely with lifestyle changes, but many do have fewer symptoms using this type of treatment. There are several drugs available on the market to relax the bladder muscle and stop it from contracting at the wrong times. Some of these medications are taken by mouth. With other drugs, patients may use a gel or adhesive patch to deliver the drug through the skin. Patients may take the drug therapy alone or along with behavioral therapy. Botox injections are also available for treatment for OAB. Injections of botulinum toxin, better known as Botox, can help patients who don't respond to other treatments. The injections into the bladder muscle may help keep it from contracting too often. There are also several different kinds of surgeries to correct stress incontinence, which occurs when the weakened pelvic floor muscles allow the bladder, neck, and the urethra to drop. These surgeries seek to lift the urethra, the bladder, or both into the normal position. This makes sneezing, coughing, and laughing less likely to make urine leak from the bladder. Surgery works to cure stress incontinence better than any other treatment. If other treatments, like pelvic floor muscle exercises to control a patient's incontinence, surgery may be the best option. What kind of surgery is done depends on patient preference, health, and the doctor's experience. Surgery is done much less often for urge incontinence, and the results are not as good. TVOTs are just a couple other procedures that are done for OAB. These procedures are used to lift a woman's sagging bladder or urethra into normal position. The procedures place a narrow band of tape under the urethra, and the tape supports the urethra and bladder like a hammock. And this is usually done for stress incontinence treatment. TVT and TOT procedures are called minimally invasive because, unlike open surgeries, they require only very small incisions in the groin, lower abdomen, and vagina. During the procedure, the surgeon passes a tape, a narrow band of synthetic material, through these cuts, slinging it around the urethra to lift and support the urethra and bladder. The surgeon adjusts the tapes during surgery to provide the right amount of support. After the surgery, the tape stays in place by friction between the tape and the surrounding tissues, and the tape does not protrude outside your body. The small stitches that close the incision slowly dissolve in the days after the procedure. So here you can see the difference between the TVT here and the TOT. In the TVT, the tape is placed through the space behind the pubic bone. And in the TOT, the tape is placed from the sides of the groin. But in both cases, it's slung around the urethra and brought back. And that's really the key difference between a TVT and a TOT procedure is the way the surgeon accesses the urethra to position the tape. Also, the tape material may differ depending on the procedure. Both procedures last about 30 minutes, and most patients are able to go home the same day. Retropubic suspension for urinary incontinence in women is also used to treat incontinence, and retropubic suspension is a surgery to treat urinary incontinence by lifting the sagging bladder neck and urethra that have dropped abnormally low in the pelvic area. Retropubic suspension is an abdominal surgery where access to the bladder and urethra is gained by making an incision in the abdominal wall. The surgery can be done by making one big incision or several small incisions. The most common procedure used for retropubic suspension is the Birch-Kopel suspension, in which the vaginal wall is attached to a ligament next to the pubic bone. Since these procedures involve abdominal surgery, hospitalization is required. To allow healing of the urinary tract, a catheter is placed into the bladder through the urethra or abdominal wall to allow urine to drain. The catheter is usually removed in about 10 days. Here you can see Birch-Kopel suspension in the sutures side. Sling surgery, urinary incontinence, and they involve placing a sling around the urethra to lift it back into a normal and to exert pressure on the urethra to aid in urine retention. The sling is attached to the abdominal wall. The sling material may be muscle, ligament, or tendon tissue taken from the woman or from an animal such as a pig. It may also be composed of synthetic material such as plastic that is compatible with body tissues or of absorbable polymer that eventually disintegrates. The sling, and it's a lot wider than what we've seen so far. Urethral bulking is another procedure to treat urinary incontinence, and it involves injecting material around the urethra. And this may be done to close a hole in the urethra through which urine leaks out, or to build up the thickness of a wall of the urethra so it seals tightly when you hold back urine. And most bulking materials are injected around the urethra just outside the muscle of the urethra at the bladder outlet. Injecting the bulking material may be done through the skin, through the urethra, or in women, through the vagina. And needle placement is guided by the use of a cystoscope, which is inserted into the urethra. Procedures are usually done under local anesthesia in women. A local anesthetic allows the person to stand up after an injection to find out if continence has been achieved. If continence has not been restored, another injection may be done immediately. And here you can see the procedure and the cystoscope that guides the place. Material can be injected. Electrical stimulation is another treatment for urinary incontinence, and it's used by sending a mild electric current to nerves in the lower back or the pelvic muscles that are involved in urination. Patients may be able to provide electrical stimulation therapy in the office or at home using a unit with a vaginal or anal electrode, and timing and duration of the therapy varies. For example, treatment may consist of 12 weeks during which the patient has 15-minute stimulation sessions twice a day, and this kind of stimulation has been used for both urge and stress incontinence. How vagal stimulation works is not well understood, The stimulation may make the muscles contract, producing an effect similar to Kegel exercises, which strengthen the muscles by contracting them frequently. The stimulation may also encourage the growth of nerve cells that cause the muscles to contract. Sacral nerve stimulation has also been used for severe urgent incontinence or OAB that hasn't been helped by other treatment. In SNS, the doctor puts an electrical stimulator under the skin above the buttocks. This stimulator looks like a pacemaker. It is attached to electrodes that send pulses to a nerve in your lower back. The sacral nerve plays a role in bladder storage and emptying. Most common device that you'll see used in our clinic, and that's Medtronic's InterStim. And here you can get a view as to where it's placed and how that electrode comes in. If you have any questions on this, by all means, just ask Dr. Beyer. I'm sure he'd be more than happy to answer any additional questions. Urinary incontinence is an inconvenient, embarrassing, and sometimes debilitating health problem, but living with incontinence can be made easier. Dr. Beyer is an expert in pelvic floor disorders and in treatments for OAB. This presentation in no way reflects all of the treatments possible. If you have any questions, remember, we have an expert in the house.